Yes, friends, now we'll be moving on to another important topic, that is corrosives, right? Corrosives, we have already discussed that corrosives are the group that will cause maximum tissue destruction. Okay. What is the other name of corrosives? Yes, corrosives also called as caustics. We can say it is caustics or we can say it is corrosives, right? Both are same. And as I told you, this is the one which can cause maximum tissue destruction on local application, right? Okay, now we'll be discussing on the different corrosives and the effects of each and every corrosives, right? Okay, broadly what we can do is we can classify the corrosives under two broad categories. Number one, it is acid. Number two, it is alkali. Okay, we have got acids, we have also got alkalis. Fine. Now, how to remember the damage? Look at the spelling of the word acid. The letter C in acid, fine, it means it causes coagulative necrosis. Acids are the substances which can cause coagulative necrosis, right? Alkalis, the letter L in alkali, that refers to liquefactive necrosis. Acids will cause coagulative necrosis, alkalis will cause liquefactive necrosis. So what is the difference? When you look at the acid, you see that, suppose, let us say this is a skin, right? And I pour acid. This acid will cause coagulative necrosis in this area. And here you can also see something called eschar. The acid combines with the adjacent tissues, it causes precipitation of proteins, it produces what is called as eschar. Because of this, the lateral spread of the acid is further prevented by this eschar, right? This is nothing due to the coagulation of proteins. This is due to the coagulation of proteins, it forms eschar, the further spread of the acid is prevented. Okay, and that is the reason why it usually, the injuries will be superficial, the damage will be superficial. When you talk about alkalis, let us assume this is a skin and I pour few drops of alkali. Alkali will produce liquefactive necrosis. So what happens is, there is no eschar formation. What happens is, the damage will keep on spreading laterally, right? The lateral spread is faster and more in case of, the lateral spread is more in case of alkali. Fine. Now, and that is the reason why if you look at the damage produced by the alkali, it will be deeper. It will be deeper, right? Acids produces superficial injury because of the formation of eschar, whereas alkali produces deeper damage. And that is the reason why in general, the alkalis are more dangerous than acids. Alkalis are more dangerous than acids. Fine, because it produces liquefactive necrosis. Fine. Now, if you look at the involvement of the tissues, in general, acids produces damage for the stomach mucosa more. Involvement will be more in the gastric mucosa, right? And similarly, sometimes what happens is esophageal mucosa involvement will also be there, but stomach mucosa involvement will be more than the esophageal involvement. When you look at the alkali, comparatively, esophageal involvement will be more than the gastric involvement. Esophageal involvement will be more in alkalis. Fine. And that is the reason why if you look at the stricture formation, the stricture formation is more with stomach in case of acids. It will be more in case of esophagus in case of alkali. Right? Strictures in esophagus will be more in case of alkalis. Right? So what you have to basically understand is, acids will cause coagulative necrosis, alkalis will cause liquefactive necrosis. It will be more dangerous than acids. Fine. All acids, they cause coagulative necrosis. But there is one important exception. The one important exception is your hydrofluoric acid. Right? Hydrofluoric acid is an acid which can even cause liquefactive necrosis, except hydrofluoric acid. In hydrofluoric acid, we can see liquefactive necrosis. It is an acid, right? But still we can see liquefactive necrosis. That is why it is unique. Right? That's why it is unique. And even hydrofluoric acid will cause more damage. It will induce more damage. Fine. Now moving further, let us look at the classification. We look at the classification. Right? So when you look at the classification, let us look at the classification, right? So you broadly categorize into acid, and we can also classify that into alkali, right? We know that. But acids can further be classified into inorganic acid and organic acid. Inorganic, and organic. Inorganic and organic. In general, inorganic acids will be having only local effects, right? It will be having effects only in the local side. If you consume, patient will be having damage in the mouth, esophagus, stomach. If you pour it on the skin, the patient will be having damage in the skin, injuries in the skin. But with regard to organic acid, it will have local effects. It will have local effects. It will also have systemic effects, because do remember, friends, the organic acids will be having systemic absorption. They have systemic absorption. In addition to the local effects, the alkalis will have systemic effects as well. So this is one important point that you have to remember when you want to understand the pathophysiology of this as inorganic acid and organic acid. Okay, so now let's talk about the examples of inorganic acid and organic acid. Let's talk about inorganic acid. What are the examples that you have to keep it in mind? Number one, it is sulfuric acid, H2SO4. Right? H2SO4, sulfuric acid. Sulfuric acid, H2SO4, which is also called as oil of vitriol. From which we got the terminology vitriolage, right? It is also called as battery acid. Do remember, friends, battery acid is different from button battery. Button battery is something where alkali involvement is there. Here battery acid, it is not button battery. Battery acid is the other name of sulfuric acid, which you have to keep in mind. This is very important for differentiation, right? The next important inorganic acid is nitric acid, HNO3, nitric acid, which is also called as aquafortis, which is also called as spirit of nitrate. Right. I would like to give you one more example of inorganic acid, that is hydrochloric acid. Easy one, right? Hydrochloric acid is an easy one which you can remember, right? Okay, now coming to organic acid. Organic acid, as I told you, it will have both local effects. It will also have systemic absorption. So what are the acids that you have to keep in mind? Number one, it is carbolic acid. Keep it in mind. You can never ever forget that carbolic acid, also called as phenol, which is basically organic acid. So that's why it has got local effects. It has also got systemic effects as well. Apart from carbolic acid, you have to keep in mind oxalic acid. You can have oxalic acid, you can have formic acid, right? You can have acetic acid. You can have a lot of examples on that. Okay, so these are the two broad groups of acid: sulfuric acid, nitric acid, hydrochloric acid. Even hydrofluoric acid also comes under inorganic acid. Organic acid, carbolic, acetic, and you have oxalic acid, formic acid. All these are your organic acid. Now coming to the alkali. Let's talk about alkali. Alkali, it's quite easy to remember. Number one, ammonia, right? Caustic ammonia. Apart from that, you can remember potassium hydroxide. Not only potassium hydroxide, you can also remember potassium carbonate, which is one of your previous year INICET question, INICET exam question. Most of the times what happens in the examination, INICET, they are more fond of massive following. You know, there is a format in INICET, massive following question, wherein one side they have given the name of the group, another side they have given the examples. You need to match the group. Okay, so potassium carbonate is alkali, right? You can also think about sodium hydroxide and sodium carbonate. Right, so these are all the examples that you have to keep in mind. They can give you examples, particularly in the examination. They can give you massive following type, which is an acid, which is an alkali. You need to match appropriately. That's very important. The next thing is moving on to management. So before the discussion of individual acid, I would like you to understand one basic thing. What is a general management in all these corrosive poisoning? Irrespective of the acid that you get, you will have one basic outline in the management. Let us discuss about the general guidelines in the management of poison. Right, the general guidelines in the management of poison. I'll tell you that general guidelines. right? Which you have to know while you are managing a case of corrosive intake. Fine. Number one in the treatment, right? Number one, fine. No, no emesis. You should not induce emesis. That will induce more damage. No lavage. There is should not be any gastric lavage, except few exceptions, right? Gastric lavage will in turn produce more damage. It will cause perforation. You're not supposed to give any gastric lavage. No activated charcoal. You're not supposed to see activated charcoal. We have discussed earlier that it is an adsorbent. It binds to it, right? It binds to the poison. But here what happens in a case of corrosive, you're not supposed to use any kind of charcoal because again it will induce more damage, right? Not only damage, it will also, there is no adsorption. Generally speaking, I told you earlier in charcoal that charcoal does not bind with corrosive. So there's no point in giving charcoal. Fine. No, nothing per oral, but most importantly, you should not give any kind of neutralization, right? You should not think too laterally that the patient has consumed acid, so I will give alkali. Both will neutralize each other, right? Patient has consumed alkali, I will give acid, sulfuric acid. It will neutralize each other. It will give more damage to the patient, right? See, whenever you give this alkali for a patient who has consumed acid, it will exothermic reaction. It induces heat. It produces heat. The patient will have the chance of perforation. It can cause stomach perforation. You are not supposed to do neutralization and all, right? So that is again very, very important, right? Nil per oral. Put the patient on nil per oral, right? You have to give IV fluids. Patient will be in dehydration. You have to hydrate the fluid properly by giving IV fluid. Patient will be having intense pain. So you have to give adequate pain relief, right? You have to give adequate pain relief. Fine. Then you have to give symptomatic measures. If the patient has got perforation, you need to give surgical management. If the patient has got infection, you can give antibiotics to prevent infections. And do remember, you can, if the patient has come less than 24 hours, you can attempt giving endoscopy. You can attempt doing endoscopy less than 24 hours to assess the damage. So these are all the guidelines that you have got if you have gotten a case of corrosive, right? Corrosive poisoning. So these are all the general guidelines that you have to remember when you're discussing, when you're dealing with a case of corrosive poisoning. Okay, right? So now we'll be discussing on individual acid. Let us take first inorganic acid. When we take inorganic acid, I told you two acids that we have to discuss, right? One is sulfuric acid, another one is nitric acid. So we'll discuss about that. Okay, sulfuric acid, another one is nitric acid. So let's talk about that. Fine. This is sulfuric acid, right? Which is also called as oil of vitriol, from which we got the terminology vitriolage. We discussed about that, right? And we also have nitric acid, HNO3. Okay, fine. Now you see sulfuric acid. Sulfuric acid basically, so this is your sulfuric acid. You can see sulfuric acid and this is nitric acid. Sulfuric acid and nitric acid. Fine. So let's see. Sulfuric acid has got two important properties. Two important properties that you have to keep in mind. Number one, carbonization. Number one, carbonization. Right? Carbonization. Everything is black and charred. Fine. And the next important property that you have to keep in mind is hygroscopic property. Hygroscopic property. Okay. It absorbs moisture from all the surface. Nitric acid. What is the most important property of nitric acid? Whenever it comes into contact with any tissue. Whenever it comes into contact with any tissue, do remember it produces what is called as picric acid. It produces what is called as picric acid, and you know very well the color of picric acid is yellowish. Right? Do remember this property of nitric acid. This property of nitric acid producing picric acid is called as xanthoprotic reaction, which is very, very important for you to remember. They can ask you in which acid you can see xanthoprotic reaction. Xanthoprotic reaction is a reaction that is seen with nitric acid. That is seen with Nitric acid. You can see whenever it comes to, let us say you take few drops of nitric acid, put it on the skin. When you put it on the skin, what happens? It reacts with the tissues. It forms what is called as picric acid. You will see yellow color skin staining. Right? You will see yellow color skin staining. Whichever part that is in contact with the nitric acid, that area will be yellowish stain. We call it as xanthoprotic reaction. Fine. Coming back, you need to see, let us say, this is a person has consumed acid. Let's not talk about sulfuric or nitric. Let us say person has consumed acid. Right? So this is the mouth, esophagus, and you can see stomach. Right? Fine. He has consumed acid. In case if the person has consumed acid, it has gone to the mouth. Let us say it is contact with the mouth. The most important feature, the most important symptom the patient comes with is pain. Right? Very, very important. Particularly what is called as odynophagia. Odynophagia is the most common symptom the patient would come with. Pain will be there. Right? Odynophagia, which is very, very important symptom, most common symptom. In addition to the pain in the throat, the patient will also have pain in the chest. The patient will also have pain in the abdomen. Pain will be there. Patient will have intense thirst. Right? The patient will have intense thirst. Can you give him something to drink? Right? Can you give him something to drink? No, you should not give, because when he drinks something, it will irritate the mucosa further. It will cause vomiting. That itself is, again, it will bring the acid out. It will cause further damage. It's a vicious cycle. Do remember, you should not give anything. Okay, patient will have intense thirst. Patient can also have vomiting. If sometimes what happens, if the blood is altered and coming out, you will get what is called as coffee ground vomitus. That's seen. Okay, fine. Suppose if the stomach, if the acid has gone into the stomach, the patient will have pain. The patient will have tenderness in the abdomen. The patient will also have bloating, distension can also be noted. If the acid is causing perforation, the acid can cause perforation of the stomach. The patient will have perforation, gastric perforation. The acid will spill into the peritoneum. It will cause acid peritonitis, chemical peritonitis. It's very important complication, peritonitis. Right? The patient will have chemical peritonitis. In case if the acid has gone into the airway, respiratory tract, the patient will have respiratory distress. The patient will have respiratory distress. Patient can present with stridor. The patient will have dyspnea, difficulty in breathing, right? Which is an emergency. Fine. So it depends on the exposure of acid. Okay, now coming to the sulfuric acid. So this is the commonest symptom that I've told you. Let's talk specific about sulfuric acid. What are the postmortem findings that you will get? Fine. Here you will get what is called as black necrotic tongue. The tongue will be necrotic, the tongue will be swollen. You will see black necrotic tongue. Okay. And if you look at the stomach, when you examine the stomach during autopsy, you can see the mucosa will be black and necrotic. Black necrotic mucosa, which is black necrotic chart. I told you carbonization, right? So it is black necrotic mucosa. Black necrotic mucosa. Look at the stomach mucosa. It is so highly damaged, it will be looking like a wet blotting paper. Wet blotting paper stomach. Okay. And you can see gastric perforation. It is one very strong acid. The chances of gastric perforation is very, very common. Right? Sometimes what happens when you open the gastric cavity, the stomach will be converted to black charred mass. It is so highly damaged. Because the sulfuric acid is so strong. You can see that everything is black. Everything is black. Black necrotic tongue, black necrotic stomach mucosa, everything is black. There's only one thing is white. What is white? Do remember, friends, only one thing is white, that is chalky white teeth. Chalky white teeth, that alone is white. Right? Teeth alone is white. Everything is black, teeth is white, chalky white teeth. Why you see chalky white deposits in the teeth? That is because of hygroscopic effect. It absorbs all the moisture from the surface. Now coming to nitric acid. Nitric acid, I told you the property xanthoprotic reaction. Is it not? Xanthoprotic reaction. But when you see xanthoprotic reaction, I told you everything is yellowish. You can see yellowish teeth. Yellow colored teeth. You can see yellow color skin staining. Not only that, you can also see yellow color stomach mucosa. Right? Yellow color stomach mucosa will be noted. Sometimes it can also be brown. That is because of the digested blood. Okay, fine. So you can remember yellow color for nitric acid. You just have to remember one reaction, that is xanthoprotic reaction. You can remember everything. Right, going forward, let us talk about one more important area, that is nothing but your vitriolage. What is this vitriolage? Vitriolage, it is intentional. Do remember the word intentional. It is intentionally done. Intentional throwing off any corrosive. Do remember the word any corrosive. You have to underline it, any corrosive. That doesn't mean, see, vitriolage means, I told you vitriolage is the term that we got from sulfuric acid. That doesn't mean always only sulfuric acid is used. If they throw any corrosive on a person with the intention to disfigure, a person, then you can call that act as vitriolage. Okay, any corrosive. What are the corrosives commonly used? Commonly used one is sulfuric acid, nitric acid, even Semicarpus anacardium plant juice, right? Juice of Semicarpus anacardium, that is also being used. Juice of marking nut, also used for this purpose, right? The intention matters. Intention is to disfigure. Right? So what are the findings that you can see in the person? When you look at the on examination, what are the findings that you can see? You can see chemical burns. You can see chemical burns on the face and eyes. Right? What are the nature of chemical burn? That you have to remember, right? You can see the presence of corrosion. You can see the presence of corrosion. You can also see the presence of ulceration. Right? But what is not seen? Do remember, friends, there is no singeing. There is no singeing of hair, because we know very well, in a case of burns, we can see singeing of hair, but here there is no singeing. In corrosive burns, there is no singeing, and there is no blisters. There is no blisters except formic acid. In general, you don't see any blisters except formic acid. Right? Okay. And because of this chemical burn, there are a lot of chances of contractures. Contractures are noted very, very commonly. It's very commonly seen with acid attack, the chemical burns. Okay, how do you treat this person? What is the treatment that you can give? First one is topical irrigation. You need to irrigate with water, or you can use saline, NS, normal saline. Okay, fine. And then what you can do is you can apply a topical paste of magnesium oxide, MgO, magnesium oxide paste. Suppose if it is exposed to the eye, what you can use is you can use olive oil. Apart from irrigation, you can use olive oil, and you can use antibiotics. You can use atropine. You can also use hydrocortisone, right? So this is the treatment that you can give for this exposure of acid to the eye. Okay. Now, when a person, see what is so important for you, why should you learn about that? One is for the treatment aspect. Another important medico-legal importance that you have to remember is, remember friends, it is so important as per 357C CRPC. As per 357C CRPC, every doctor should compulsorily treat the victims of rape and vitriolage. You cannot refuse treatment. At least you should give first aid treatment. Right? Compulsory. It's not optional. Compulsory. Right? You cannot refuse treatment. It is the compulsory treatment for such kind of victims by the doctors should be given. At least you should give first aid. Otherwise, if you refuse to give treatment for such victims, you are punishable as a doctor, right? You are punishable. So if there is an acid attack, if there is an attack of vitriolage, it is punishable under 326A IPC, right? Punishment of acid attack. But do remember, it is not only the attack as such, it is punishable. Suppose if somebody is trying, if somebody is attempting, he has thrown acid, but the victim moves, it has fallen on the ground, that amounts to attempt. Even that attempt is also punishable. That is punishable under 326B IPC, punishment of attempt of acid attack. Right? 326B IPC. Punishment, right? So it has to be coming under IPC. Fine. This is a procedure. It comes under CRPC. 357C CRPC, which you have to remember. If you are neglecting, if you are refusing to treat the victim of vitriol, you are punishable. Right? You are punishable. You can see this is the patient of vitriol, victim of vitriol, okay, throwing of acid. And I told you that the doctors will be punished if they are not giving treatment. And do remember, as per 357 CRPC, the first aid has to be free of cost. You should not charge the patient, and you should also intimate the police from your side. Right? Police intimation has to be done by the doctor who's treating the victim. You cannot ask the victim to go to the police station and file a complaint. It's not like that. It is a duty. It is the responsibility of the doctor to inform the police as per 357C CRPC. Otherwise, it is punishable. Okay, we'll be discussing this section in detail later again in legal section chapter. Now we'll come back to this. Okay. Fine. Now, moving to the next important acid. So, we have discussed about sulfuric acid. We have discussed about nitric acid. Now, the next important acid is organic acid. One organic acid which you know very, very commonly, which you commonly see every day, and it is very popular. What is that? It is phenol. Right? Phenol. What is the other name of phenol? Phenol is also called as carbolic acid. You know that? It is commonly used as antiseptic. It is as a disinfectant. It's an antiseptic, it's a disinfectant. Right? We commonly use for floor cleaning, we commonly use for toilet cleaners. In all these places we use. See, when you take pure phenol, this is the appearance. It's crystal, prismatic crystal. Right? Pink color. What happens when you expose it to air? It turns into pink liquid. What you can see. Right? On the left side, you can see this is your pure phenol. This is the liquid that you can see. On exposure to air, it turns into liquid. Fine. Now, let us say this phenol, this is the phenol. What are the derivatives? What are the products of phenol? You can say cresol, resorcinol, lysol, dettol. All these are the derivative of phenol. These are all phenolic derivatives which we use in multiple commercial preparations. Fine. See, when you talk about absorption, there is one important thing. See, phenol is something which is absorbed in all roots, even through intact skin. Even through intact skin, you can see, even through intact skin, it can be absorbed. It is absorbed through all roots. All roots, which is very, very important for assessing the toxicity of the phenol. Fine. Let us assume patient has consumed phenol. Right? Let the patient has consumed phenol. Okay. It has gone. This is the mouth, esophagus, and this is stomach. Right? Okay. Patient has consumed phenol. In general, as it is an acid, it has got some corrosive effects. What are the corrosive effects? The patient will have pain. Patient will have pain will be there. But here what happens, you see, it's very important. Initially, the patient will have burning pain. What happens after some time? He will start feeling tingling. Tingling and numbness will be there. What happens after that? After some time, it will be totally anesthetized. There is anesthesia. There is no sensation at all because the phenol destroys the sensory nerve endings. Initially, there is pain. After some time, tingling, numbness, and there is no pain at all. Total anesthesia will be there. And that is the same reason why the patient will have reduced emesis. Emesis is less. Vomiting is less. Right? Vomiting is less. Because you know very well, sulfuric acid, nitric acid, it is irritating the sensory nerve ending. You will have lot of thirst and vomiting. But here the patient is not having lot of vomiting. That is because of the anesthetic effect of phenol, carbolic acid. This phenol, I told you, it has got local effect. So what we have discussed so far is local effect. What we have discussed so far is a local effect, and it has gone into the stomach. In the stomach, what happens is it produces what is called as leathery stomach mucosa, thickening of the mucosa. It causes thickening of the mucosa. We call it as leathery stomach mucosa. And that is the same reason why we discussed earlier. Here we can give gastric lavage. This is one acid where we can give gastric lavage because it causes thickening of the mucosa. Thickening of the mucosa. Fine. Now, we have discussed about the local effects. Now, I also told you carbolic acid will have systemic effects also, systemic absorption also. This carbolic acid is absorbed into the blood. When it is absorbed into the blood, it gets metabolized. Right? It gets metabolized into two important metabolites. What are the two important metabolites? The two important metabolites are the phenol gets metabolized in two important metabolites. Number one, look at the spelling of the word phenol. The first letter is P. We call this as pyrocatechol. Right? What is the second letter of the word phenol? The second letter is H, right? So that means it is hydroquinone. Easy to remember, fine? So it is pyrocatechol hydroquinone. Two important metabolites of phenol which produces a lot of toxicity. Fine. Now let us say two metabolites are formed. These two metabolites will get deposited in many places in all the tissues. It gets deposited in many places, many tissues. It induces black discoloration, black color deposition in all the tissues, skin, cornea, ligaments, joints, wherever it gets deposited, black discoloration will be there. Do remember, friends, this particular term is called as ochronosis. Right? This is very important. This we call this as ochronosis. Ochronosis. Fine? Ochronosis. Right? Now what happens? These are all very toxic things. Right? Toxic, pyrocatechol, hydroquinone, they act directly on the CNS. Right? They're directly on the CNS. It causes CNS depression. It causes CNS depression. The patient will also have convulsions. Right? Patient will also have convulsion. One more very important point for MCQ purposes, it causes constriction of pupil. Right? It causes constriction of pupil. You can remember CCC. Right? CNS depression, constriction of pupil, and also causes convulsions. Right? It also acts on the CVS. It can cause shock, it can cause arrhythmia. Multiple effects are there on the CVS as well. Now, these metabolites are toxic. It has to be excreted out of the system. Who is excreting this out? The kidney is trying to excrete it out. Right? The kidney tries to excrete out in the urine. It is trying to excrete it out in the urine. In the urine, you can see these metabolites. Fine? In the urine, you can see these metabolites. We see that it is called as carbolyuria. Right? Carbolyuria. When you look at the urine, when you expose it to air, it turns into green color. It turns into olive green color. Very important. They'll ask you in which poisoning you get green color urine. In which poisoning you get green color urine, olive green color. Sometimes you can also see dark color urine, dark urine. Okay, patient has come with unknown poisoning. He is passing urine. Urine is turning into green color. Urine is turning into dark urine. Right? What is the poisoning? It is carbolic acid poisoning, phenol. Okay, so this is carbolyuria. But these two metabolites are so toxic, it can cause tubular damage. It can cause tubular damage. Patient can present with renal damage as well. Tubular damage. Patient can present with tubular damage. Patient can have renal failure. Patient can present with oliguria. All renal toxic symptoms can be noted. Fine. The kidney tries to excrete this, but there can be tubular damage as well. Tubular damage as well. So all these are the features that you have to see, you have to learn if you're talking about phenol. I've given you everything in one slide. Right? I told you about local effects, that it is having a burning pain and leathery stomach mucosa. It is absorbed into the circulation. It produces two important metabolites. Number one, pyrocatechol hydroquinone. I told you ochronosis, it is a black deposition, and also told you carbolyuria. One MCQ point I told you to remember, it causes constriction of the pupil. Fine. So all these features are seen with acute phenol poisoning. Do remember, friends, the acute phenol poisoning, what we have seen now is called as carbolism. Right? Easy to remember, friends. Carbolic acid carbolism, right? Suppose if the patient is coming with chronic phenolic poisoning case, that condition is called as phenolic marasmus. Acute poisoning is called as carbolism. Chronic poisoning is called as phenolic marasmus. Is what you need to remember. Okay, they can ask you what is carbolism. We have discussed all the features of carbolism. Okay, let us assume patient died in case of phenolic poisoning case. Patient died due to phenolic poisoning. During autopsy, what you can notice is phenol delays putrefaction. Phenol delays putrefaction. Can you tell me the logical reason why? Can you tell me the logical reason why? I told you earlier that phenol is basically antiseptic. Right, so it is having antiseptic effect. That is the reason why it delays putrefaction, because you know very well for putrefaction you need bacteria. Okay, bacteria. Assuming a patient has come with unknown poisoning, how do you diagnose that he has consumed phenol carbolic acid? Right, what are the symptoms? What are the features that will suggest that the patient has consumed phenol only? Nothing. One thing, you can find out the urine. The specific odor that you have to remember, you all know phenol has got phenolic odor. We call it as hospital odor. We also call it as phenolic odor. The typical smell will be there. Phenolic odor or hospital odor that will be typically present in the patient, that you can easily find out. Okay, and dark color urine will also be adding importance for it. Suppose if the patient has come with poisoning and you want to treat this condition, how can you treat? The first one is decontamination. Decontamination, I told you, normally we give gastric lavage in all poisoning. In acid poisoning, we don't give gastric lavage because of the fear of perforation. But this is one important exception for that. Gastric lavage can be given with caution. That is important, with caution. Why you can give gastric lavage in this patient? Because it causes leathery stomach mucosa. So you can give gastric lavage. And other treatment is basically symptomatic, depending on whether the patient is having convulsions, whether the patient is having arrhythmia, whether the patient is having shock. So depending on the symptom, you can treat the patient. Okay. Yes, friends, we'll be starting with another important acid, that is your hydrofluoric acid. This acid is so very special, right? You know why? You know why it is so very special, so very unique, right? Why is it so unique? Because this is an inorganic acid. This is an inorganic acid, but it has got both local effects. It has also got systemic effects. It will cause damage locally. It will also cause systemic absorption. And this is another important acid where, this is one important acid, only one acid where you will have systemic effects even on local application. See, normally sulfuric acid, you put it on the skin, it will have local damage. You put any other acid on the skin, it will cause only local damage. But here, this is hydrofluoric acid where you will have acid, put it on the skin, you will have systemic effects on local application, right? It is absorbed through the skin. That is more important. It is absorbed through the skin. So it is unique. It has got both local effects. It has also got systemic effect. Another important uniqueness is it is an acid, but it can cause liquefactive necrosis. It is an acid but it can cause liquefactive necrosis. Okay, so these are the two important uniqueness it has got. Let us talk about the toxicity. What are the important toxicity we have? See, this hydrofluoric acid, it produces two important ions. One is H plus ions. It has also got fluoride ions. But this fluoride ions is so dangerous. It's so dangerous. The toxicity of hydrofluoric acid is primarily due to the fluoride ions. We'll discuss about that. This fluoride ions, what happens is it will cause liquefactive necrosis. I told you just now. It will cause liquefactive necrosis. When you know very well it can cause liquefactive necrosis, the local spread will be faster. So what happens? It will damage the skin. It will damage the deeper tissues. It will also damage the bones as well, right? All the tissues are completely destroyed by hydrofluoric acid. And see, the patient will be having excruciating pain, excruciating burning pain, which is disproportionate to the amount of exposure. right? He would have put only few drops of acid, but the patient will have severe pain and severe burns will be there. That is because of the extensive damage produced by hydrofluoric acid. Okay, disproportionate to the amount of exposure. The second important property is it will cause, it combines with calcium, it combines with calcium and magnesium ions. In the body, it combines with calcium and magnesium ions to form insoluble salts. Insoluble salts. So what? So what? Because of this, do remember the patient can present with hypocalcemia. The patient can present with hypocalcemia, the patient can present with hypomagnesemia, the patient can also be presenting with hyperkalemia. These are the three important electrolyte disturbance that you will notice in this patient. Hypocalcemia, hypomagnesemia, hyperkalemia. This is so very important. So very important. Okay? Fine. So I've told you two properties and two effects. One property, liquefactive necrosis, burning pain. I told you it combines with calcium magnesium. I told you the electrolyte disturbance produced by it. If you remember these 2 points, it's sufficient that you can answer questions on that. In one of your previous JIPMER exam, you got a question on that. Which of the following is not seen with hydrofluoric acid? Fine. Hypocalcemia, hypomagnesemia, hyperkalemia, hyponatremia. Do remember, sodium is not affected here. Hyponatremia is not produced by hydrofluoric acid. Only these three important features are produced. Suppose a patient has come with hydrofluoric acid exposure, what you should do? One important thing is immediately you need to admit him in ICU. Right? And you need to look for continuous ECG monitoring. Why do you want to look for continuous ECG monitoring? Because the patient may develop arrhythmia. Not only that, you check for the electrolyte levels, you find out what is anomaly, and you have to correct it. That will be the treatment. Right? Topically, what you have to do is intense irrigation. Topical decontamination has to be done. It is so very important. Intense, plenty of water has to be used. Topical decontamination has to be done. Okay, not only that, if available, you can apply a topical local application of 2.5% calcium gluconate. Right? And if the patient, I told you that you need to check for electrolyte levels based on whatever is electrolyte level, based on whatever electrolyte results are coming, you have to treat the patient accordingly. And IV calcium gluconate, you have to give calcium gluconate. You need to give calcium gluconate, right? Injection. You may have to give it in subcutaneous, you may have to give IV. Sometimes in severe cases, you should also be able to give an intra-arterial, right? In this case, intra-arterial injection of calcium gluconate is also being done. As I told you earlier, correct the electrolytes level, right? You need to correct this electrolytes level. Fine. So all these things have to be managed with hydrofluoric acid. This is so very painful exposure. Okay, very, very painful exposure. Hydrofluoric acid. It will destroy the skin, it will destroy the tissue, it will destroy even the bone. Okay, very dangerous. This hydrofluoric acid is commonly used in this kind of glass etching. So people who are exposed to this kind of occupation where hydrofluoric acid is very commonly used, this risk of hydrofluoric acid exposure injury is very common. So you need to treat accordingly. So patient doesn't know, patient may not be knowing that the patient has got hydrofluoric acid exposure, but he might tell you that I was working in this kind of occupation, glass etching thing, and the solution which was used in glass etching was exposed to this particular area. Then you can think of hydrofluoric acid and you have to treat accordingly. Okay, so that is very, very important to remember. Okay, fine. Let's move on to another acid. Now we'll be discussing on one organic acid, that is oxalic acid. Oxalic acid. This oxalic acid in olden days, see, this is also called as acid of sugar. This is also called as acid of sugar. Acid of sugar, which is closely mimicking It looks like magnesium sulfate. It looks like magnesium sulfate. That's why accidental exposure is very common. Very common. So this oxalic acid in olden days, it was normally used as ink remover solution. They used to have it in ink remover solution, rust remover, stain remover. Very commonly it was used. Okay, fine. So they use it for signature forgeries and all. But if anybody is basically involved in this kind of signature forgery with oxalic acid, you can punish the person with 463 IPC. 463 IPC, which is basically not so important, but still you remember the person can be punished for cheating, forgery. Right, moving further, let us say patient has come with consumption of oxalic acid. But before that, what are the sources of oxalic acid? You can see the oxalic acid, this is oxalic acid. I told you that is basically acid of sugar, this is acid of sugar, which is actually looking like magnesium sulfate. That's why accidental exposure is common. And you can see that there are a lot of sources of oxalic acid is available in all these areas, vegetables, spinach. You can see it's present in corn, it's present in almonds. In many places you can see this oxalic acid. So assuming that patient has got accidental oxalic acid exposure, or he has consumed oxalic acid intentionally, what happens? Oxalic acid, it enters into the stomach. Oxalic acid, it enters into the stomach, right? GAT, where the patient can have local effects. The GAT, the patient will have local corrosive effects. What is that local corrosive effect? The patient can have pain, the patient can have vomiting, right? All these things will be there. Local corrosive effects can be noted. Fine. Now, I told you it is organic acid, right? So it will have systemic absorption. Let us say it is absorbed into the blood. It is absorbed into the blood, but in the blood what happens is the oxalic acid, do remember friends, the oxalic acid combines with calcium. Normally you have calcium in your body. This oxalic acid combines with calcium to form calcium oxalate crystals. It forms calcium oxalate crystals. These calcium oxalate stones are formed. It will be circulating in the body, right? It will be circulating in the body. What happens? See these calcium oxalate crystals. So it will be excreted in the urine. You can see the kidney is trying to excrete it out. You can see lot of stones, lot of cast coming out in the urine. Right? We call that as oxaluria. Wherein you can see envelope shaped. You can see this kind of cast, right, presenting in the urine. Not only that, you can also see needle shaped cast. You can see needle shaped cast. You can see envelope shaped cast will be presenting in the urine. Okay, you can easily diagnose that it is oxalic acid crystals. And you know that it is oxalic acid poisoning. It is excreting out. But the problem is what happens? This oxalic acid cast will be blocking the tubules. We call it as tubular precipitation. It may get precipitated in the tubules itself. It is coming out, it is fine. If it is coming out in the urine, it is fine. But what happens is it will get precipitated in the urine. It will cause renal damage. The patient can also present with oliguria. If it is so severe, it can even cause renal failure also. Right? It's so very important. Fine. Now, what happens is you need to see this. I've told you that you need to remember renal toxicity. I've also told you that what is actually happening? The oxalic acid combines with calcium. So what are you doing? You're consuming all the calcium out. When you're consuming all the calcium out, what happens to the inherent calcium level in the body? The inherent calcium level in the body will be dropping down. What happens? The patient will be presenting with what is called as hypocalcemia. Right? The patient will be presenting with hypocalcemia. You can see the patient will be presenting with features of tetany. You can see Chaucer's sign, Trocheau's sign that can be noted in oxalic acid poisoning. Okay, oxalic acid poisoning. Hypocalcemia will be noted. So that is the reason why when such patient is coming to the treatment, right? Obviously you have to do decontamination, right? What you can do is, if suppose if you are able to gastric lavage with caution, you can use calcium lactate solution for gastric lavage. What is the most important antidote that you have to give? You need to know the most important antidote here that you can give is calcium gluconate, right? What you can give is calcium gluconate, that has to be given here. Fine. So that is very, very important because the patient is presenting with hypocalcemia. So you have to give calcium gluconate. Okay. Not only that, you can also give hemodialysis if it is so severe poison. Hemodialysis. And if the patient is presenting with renal toxicity, you have to address the renal toxicity as well. Okay. So these are all the features. I've given you all the features in one particular slide so that you will remember this. Okay, and I would like to show you the oxaluria as well. I'll show you the oxaluria. Have a look at this. This is how the oxaluria will appear. You can see oxalic acid crystals in the urine. Okay, you can see envelope shaped crystals. Right, so typical, so very typical. Okay, fine. Now we'll move on to another acid. Another acid, I just want to have an idea about this, boric acid. We are not going to discuss in detail. I'll just tell you one important finding alone. Boric acid toxicity is one which produces what is called as boiled lobster syndrome. Boiled lobster syndrome. They say that it looks like boiled lobster. The peripheries, particularly the fingers and toes, will be swollen, reddish, looking like what is called as boiled lobster. Okay, boilers. People who have eaten lobster, boiled lobster, they might be able to appreciate this. You look at the skin of this patient. The skin of this patient will be erythemic. Erythemic. They call it as beef red. Beef red. Right? You can see peeling of the skin. Intense peeling of the skin. Desquamation can be noted, and it is completely swollen. Okay, so you call it as boiled lobster syndrome. It looks like a boiled lobster. We see that with boric acid. Sometimes they say that it is a condition that mixes staphylococcal scalded skin syndrome. Okay, so you remember this. This is boric acid. Fine. Okay, so I've told you all the important poison that you have to remember. Thank you.